Welcome to this session, and my name is Nikita. I'm a nurse practitioner. I work primarily at the BC Cancer, and also I'm a member of the Prostate Cancer Supportive Care Program team, and I specifically discuss the side effects of the androgen deprivation therapy and how patients can mitigate some of the side effects of the androgen deprivation therapy and improve their quality of life. So today's sessions will be specifically focused on discussion on how patients can prevent side effects of androgen deprivation therapy and how they can improve their quality of life. So today we're going to talk about how does androgen deprivation therapy works, what are the side effects of the androgen deprivation therapy, and what is the side effects that you are most concerned about. So a lot of patients are concerned about the Gleason scores, about the cancer diagnosis, and the question is, why did it happen to you? So prostate cancer, in fact, is very common cancer. And this is the most common cancer in Canadian men. 1 in 7 men will have a chance of the prostate cancer in their lifetime. And about 21,000 patients will be diagnosed with prostate cancer in Canada, and about 4,100 will die from prostate cancer. To put it into the perspective, every day about 56 to 60 patients are diagnosed with prostate cancer, and about 11 men die with prostate cancer. But luckily, majority of the prostate cancer is caught either in local stage or local regional stage. And those patients who undergo surgery or radiation therapy have about 80 to 99% of overall 10-year survival. So a good chance for those patients to live 10 years and longer. And if you consider that the majority of patients are diagnosed at the age of 70, those patients live into 80s and mid-80s who are diagnosed with prostate cancer. There is a little bit of a different prognosis for patients who are diagnosed with metastatic disease at diagnosis. The 5-year survival is about 30 to 50%. But again, every year we continue to find new treatments for the prostate cancer and continue to improve the overall survival of patients with metastatic prostate cancer as well. So androgen deprivation therapy can be given with primary therapy, for example, surgery or the radiation, and majority of patients might experience some side effects from the primary therapy, which can be surgical, radical prostatectomy, or radiation therapy, which could be brachytherapy or external beam radiation. And majority of those symptoms are related to sexual and urinary function. So androgen deprivation therapy has a unique set of the side effects as well, which can also exacerbate already existing side effects from the primary treatment. So why do we talk about the androgen deprivation therapy? Back in around 1950, Dr. Charles Hyans discovered that whenever he removed testosterone from men with prostate cancer started to live longer and had less pain. Prostate cancer is dependent on testosterone. So to speak, testosterone is a food for prostate cancer. And testosterone is a male hormone which is produced in males throughout their lifespan. It peaks around puberty and slowly decreases with age. In about 1980, alternative methods to controlling testosterone were developed, and most men now prefer injections to surgery. So how there are, again, a variety of treatments. There are two main ways how we can control testosterone in males. One is the surgical approach, and another one is the medical approach. The surgical approach, the name is orchiectomy. It's a procedure of removing testes. And medical approach is with injections, either controlling testosterone with the stimulating hormones or with inhibitors. With orchiectomy, it's done once, and then testosterone is removed from male body forever, so it's irreversible. With the medical castration, there is an option of reversing low levels of testosterone. As patients stop the injections, the testosterone will rebound with time. In terms of how fast it works, both orchiectomy and inhibitor will start working within 3 to 4 days. They will lower testosterone to castration levels within a week, and it takes about 3 to 4 weeks for testosterone to be lowered with agonist, with the injection which actually stimulates initial production of testosterone. And majority of patients are now receiving agonists, and the most common one is Zolodex or Goserelin. With the stimulators, there is also a risk of having a flare-up, meaning that the patient's initial testosterone levels are actually increased with this type of androgen deprivation therapy. And for this reason, majority of men who are put on this therapy, they took oral androgen inhibitors. Majority of patients don't experience any local reaction or any complications after surgery or with agonist therapy, but a number of patients do experience significant local reaction with antagonist. And they might experience swelling and burning at the site of the injection. Administration with orchiectomy is only required once. With agonists, it's every 3 to 4 months, and with antagonists, it's on monthly basis. And that's why majority of the time agonist is preferred method, because patients can have injections or need injections every 3 to 4 months rather than monthly. There was research in regards to cardiovascular complications, but again, it's still in the beginning stage. And at this time, we believe that cardiovascular risks from all those treatments are practically the same. In terms of preference, majority of patients actually would prefer the medical way of controlling their testosterone rather than surgical. In terms of cost, the orchiectomy costs in about hundreds, and patients generally with prostate cancer will live for a long period of time. So the cost for one injection is about $300 to $500, so the cost will amount to thousands. And of course, it's covered by BC Medical. Here's the slide just to illustrate for you the most common options of controlling testosterone. So as I mentioned, surgery called orchiectomy. You don't have to remember the whole name for the treatment, but it's luteinizing hormone releasing hormone agonist. And examples most commonly use Zolodex, Lupron, Eligard, and Goserelin is generally not used in British Columbia. Then there is only one antagonist called Degarelix or Firmagon. And then there are anti-androgens, which sometimes used to augment the effectiveness of agonists. But the combination of those two treatments lead to more cardiovascular complications. So I have a number of patients who come to me and talk about the androgen deprivation therapy side effects, and they are aware about different options of controlling testosterone. So they ask me, can I be switched from Zolodex to Eligard, or if they're on Eligard, can be switched to Zolodex because I experience so much fatigue, muscle loss, or hot flashes. And I generally tell my patients that unfortunately it doesn't matter which injection I give to you, the side effects will tend to be the same. And the reason for this is because the majority of the side effects are not related to the injections, but they are actually related to the low levels of testosterone. And why is that? Is because testosterone is responsible for many functions in male body, including for maintaining health of the skin, muscle, bone marrow, brain, heart, liver, kidney, and helping to maintain sexual function and libido. So the side effects of the androgen deprivation therapy fall into several categories. The first is what physicians commonly tell you. And if you go and discuss the side effects of androgen deprivation therapy with either your radiation oncologist or your urologist, they will talk about the loss of libido, loss of erectile function, and hot flashes. So, unfortunately, men tend to experience a lower sex drive on the androgen deprivation therapy, and again, unfortunately, there is no magic pill for it. It is also age-related. As I mentioned before, the testosterone tend to decline with age, and men of age tend to experience a little bit of less of a libido. So there is less of libido in 70s than in 20s. And this is expected. So the younger man on the androgen deprivation therapy might experience more side effects in terms of loss of libido than the man at the oldest age. And although there is no magical pill to improve libido, exercise showed that it can help to boost libido, as well as it is advised to bring partners into the conversation in terms of how libido can be improved. And I always recommend my patients to attend module on sexual health and talk to the sexual health providers. In terms of the erectile function, or rather erectile dysfunction, addition of androgen deprivation therapy lowers sex drive. And often, if men never experienced any erectile dysfunction before the androgen deprivation therapy, they might experience some erectile dysfunction on the androgen deprivation therapy. Again, my recommendation to talk to the sexual health provider, because there are a variety of ways how men can improve their erectile function. And the most commonly used ones we all heard on the TV or have received ads on the internet is Cialis or Viagra. There are also possibility of injection of the medication directly into penis, and to help vacuum erection devices also can improve erectile function. And of course, again, it's recommended to bring your partners into discussion and incorporate couple-based counseling and education. And the main point I want to make with this is that although some patients have a lack of erection or not able to achieve full erection, orgasm is still possible. Hot flashes, another debilitating sometimes side effects of the androgen deprivation therapy. Patients come to my clinic and tell me that we don't experience any hot flashes. Other patients come to me and say that, I have no quality of life because of the hot flashes. I didn't attend my daughter's wedding. I stopped going out with my friends. I have no quality of life, and despite that, stopping androgen deprivation therapy could harm them, they decide to stop androgen deprivation therapy. So hot flashes usually appear within 2 to 3 months of start of androgen deprivation therapy. Patients do initially experience quite significant hot flashes, and however, they tend to abate as the time progresses. So some of the aggravating factors, alcohol, spicy food, and caffeine can exacerbate hot flashes, as well as heat and stress. And from personal experience, whenever patients being told that certain foods can exacerbate their hot flashes, they say, "Oh, it's probably not true." But I had a number of patients who come to me and said, one of the experience I had with a patient who lives outside of Vancouver and comes to visit Vancouver, besides seeing us, he enjoys eating out in Vancouver. And he tells me, I had the most severe hot flash yesterday to the point that my knees buckled. And I started discussing with him what happened. I had the spiciest food in my entire life. Spices sometimes, as well as other foods, might exacerbate hot flashes. Caffeine and alcohol also might do that, but I never recommend my patients not to drink alcohol, not to drink coffee, or not to eat spicy food. My recommendation is everything in moderation, because I don't want to put an additional pressure on the patients of stop doing things that they actually like. Some non-pharmacological methods of controlling hot flashes, again, regular exercise, wear layers of clothing, again, sleep with layers, stay cool and hydrated, relaxation exercises, and acupuncture specifically has been shown to improve hot flashes. And if someone wants to pursue acupuncture, you will need to find an acupuncturist who specializes in treating hot flashes, because there are specific points that were researched that help with hot flashes. There are some pharmacological methods of controlling hot flashes, and I'll just switch to the next slide that show a number of medications that have been helpful and non-helpful for treating hot flashes. So here at the top there is a placebo, and in this trial patients started at the maximum intensity of the hot flashes. So they rated their hot flashes as 10 out of 10, and this is the time. So the patients were evaluated on those medications as time progressed. So all those treatments such as black cosh, soy, or vitamin E were around placebo. So pretty much those medications has been shown to be non-effective in controlling hot flashes. But remarkably, you can see that even placebo in itself lowers the intensity of hot flashes. So if patients think that they're taking something for hot flashes, the intensity of hot flashes will be reduced. The most common methods of controlling hot flashes are Effexor and pregabalin. Those medications do have certain side effects, and the main side effects is drowsiness and fatigue, and that's why sometimes patients start taking them and they already a little bit fatigued and they experience more fatigue with those medications, so they stop, and they don't have any relief from their hot flashes on the week 1 and week 2, so they stop taking the medication. But in fact, the best effect from those medications was observed on the week 4. So my recommendations to patients, if they start taking the medication for their hot flashes, do continue to take medication for the period of 4 weeks and then decide if the medications are not effective. My only caution would be vitamin E. There was a trial where there was a belief that patients might benefit from the high doses of vitamin E and can stabilize the disease, but it's been shown that patients who didn't have prostate cancer started to had more cases of the prostate cancer in the arm where they were receiving high doses of vitamin E, as well as patients with a lower grade prostate cancer started to develop more advanced cancer as well. So that's why I recommend all my patients first to discuss alternative treatments with your healthcare providers, because some of those treatments do have potential side effects and can harm you. Another side effects of androgen deprivation therapy is actually what you can see. And patients might experience weight gain, gynecomastia, which is another word for increased in breast size, a loss of muscle mass and strength, decrease in size of the penis and testes, and changes in their hair. About 40% of men who already come to our clinics, they already have some issues with weight, either overweight or obese. It is not uncommon for men on androgen deprivation therapy to gain about 5 to 10 kilograms within a year. And it's specifically increased not in a lean body mass, but rather in a fat body mass. And at the same time, men are usually lose their lean body mass. If the patients are on intermittent androgen deprivation therapy, the weight that they gained during the androgen deprivation therapy is very difficult to lose once they stop androgen deprivation therapy. So that's why I advocate for all my patients to exercise, and not only aerobic exercise, but also resistant exercise to maintain muscle and bone health and strength. A lot of patients already come to our clinics and they say that I exercise throughout all my life, and I developed a certain program that works for me, but I still recommend to talk to our exercise therapist, because sometimes it's hard for the patients to get this initial boost to get to the exercise. So develop a really good program to incorporate both a right amount of aerobic and resistance exercise. Those are the general recommendations for patients who do not have cancer, but it's same hold for patients who have cancer, and it basically talks about the maintaining healthy lifestyle. Shrinkage of penis and testes. About men potentially can lose about 1 to 1.5 centimeter of the penile length within a year of starting androgen deprivation therapy. And again, I want to point out that this is the maximum. Generally, men do see some reduction of the penile length, and generally it happens because of the lack of the blood flow into the penis, because men have less erections, and then there are changes in tissues of the penis which sometimes can be irreversible. So it is correctly pointed out here, erections equals erections. I recommend all my patients to continue to stimulate themselves in the shower and bring the blood into the penis and maintain the health of penile tissues. Hair changes, of course, it's not as drastic as shown on the picture. Men tend to lose hair primarily on the body, not on their head or on their face, but they might find that their beards became softer once they started the androgen deprivation therapy, and they don't have to shave as often. The good news about this, when androgen deprivation therapy stopped, the hair will regrow back.
Okay.
There are also some changes that patients actually don't see. And those changes occur with the bone, in the blood, as well as patients might experience changes in their cholesterol profile and their blood sugars, and changes in their blood pressure as well. Loss of bone density. So testosterone stimulates growth of the bone, as well as it stimulates and maintains muscles, which exert pressure on the bone, which stimulates bone to grow. Men who are on androgen deprivation therapy tend to lose bone density 5 times faster than the men who are not on androgen deprivation therapy. And men in their 70s, again, some men in their 70s already predisposed to having osteopenia or osteoporosis, which can lead to increased risk of fracture. So the recommendation is to start vitamin D and supplement with calcium as well as soon as men start on the androgen deprivation therapy. There is also recommendations to have a bone density scan, and I know that a lot of patients already had a bone scan, which is different, which specifically looks at the metastatic disease. Bone density scan looks at the density of the bone, looks at how healthy the bone is and what is the chance of fracture within the next 10 years. The main recommendation is, again, exercise, and specifically resistance exercise. If men already fall into the osteoporotic range, meaning that their risk of fracture within 10 years is more than 20%, then there is a recommendation to be referred to the endocrinologist and to have a discussion in regards to studying on the medications which can stimulate bone to grow or to stimulate health of the bone. The next slide basically explains to you what happens with bone as men start on androgen deprivation therapy. The top of the slide shows healthy bone with a thick cortical layer and strong inner structure, and as men continue on the androgen deprivation therapy, they lose, and if they don't exercise, they start to lose bone density, which can lead to thinning of the outer layer of the bone and the loss of inner structure, which can lead again to increased risk of fractures. Androgen deprivation therapy also lead to the increased risk of diabetes and cardiovascular disease. We know through research that about patients who are on androgen deprivation therapy have a higher risk, about 10%, of developing diabetes, cardiovascular disease, or myocardial infarction. Men are also at an increased risk of developing metabolic syndrome, which include any 3 out of 5 conditions, such as increasing in accumulation of fat around the abdomen, increasing in insulin resistance, increase in cholesterol levels, and increased in blood pressure. So metabolic syndrome, as I said previously, that men tend to gain 5 to 10 kilograms in weight when they started an androgen deprivation therapy. They might have an increase in their blood sugars, especially if men previously had a pre-diabetic conditions, that they are higher risk of developing diabetes. Lipids tend to increase in unpredictable ways, so sometimes patients experience no increase in the bad cholesterol, but they might experience lowering of the good cholesterol. Given the fact that the patients start to accumulate weight and tend to be more fatigued, and they exercise less, and they start to have an increase in blood pressure as well, which is again a leading cause or a leading risk rather for patients developing stroke or cardiovascular event. And patients who previously patients who have a history of cardiovascular disease are at more risk than patients who never had a previous cardiovascular disease. So my recommendations for those patients is to have a frank conversation with a family provider or GP and have a baseline measurement of the blood sugars, lipids, blood pressure, and monitoring of weight, and repeat those measurements on a yearly basis when men on androgen deprivation therapy. As presently, there are no absolute guidelines for men on the androgen deprivation therapy and how they should be screened and monitored. And that's why part of this program is to conduct research and to look how we establish guidelines and improve overall health of men on androgen deprivation therapy. One approach to it is easy to remember, ABCDE, to be aware about the signs and symptoms of heart attack, aspirin for patients who previously had cardiovascular event or have a history of cardiovascular disease, monitoring blood pressure or start the medications which will lower the blood pressure, and the general recommendations for the patients to have blood pressure lower than 130 systolic and 80 diastolic. Monitor cholesterol levels, smoking cessation, adjust diet, get a grip on diabetes control, and of course exercise. Lifestyle modifications, again, reduced intake of saturated fats and trans fat can reduce cholesterol levels by about 9 to 12%. In some studies, red yeast rice has been shown to decrease lipids as well as statins. And I just looked online today, there is those the red yeast is available in pill forms. Also, Mediterranean portfolio diet was shown to reduce cholesterol levels. And again, the most effective is usually a combination of both exercise and healthy lifestyle or diet. This is just to show you how both reducing of weight, diet, reducing intake of salt and physical activity and alcohol can improve blood pressure without resorting to medication. So there are some side effects of the androgen deprivation therapy that are not commonly talked about, that what you actually might feel. And patients might experience fatigue, muscle and joint aches, emotional liability and depression, and some brain fog as well. A lot of patients who come from our clinics do start to experience pains and aches in their muscles and joints within 3 to 4 months of starting androgen deprivation therapy. And it is believed that it's due to changes in the muscle mass, ligament thinning, as well as a reduction in fluid which lubricates the joints. Again, the best remedy for this is exercise, again, to maintain muscle strength, and which will in turn will maintain the health of the joints. Acupuncture and massage therapy, and some medications which are commonly used like NSAIDs, Advil or naproxen is recommended as initial therapy if men experience significant symptoms. Men who are on androgen deprivation therapy are at higher risk of developing depression as well. And especially men who previously developed depression are even at higher risk for developing a clinical depression on the androgen deprivation therapy. My recommendation to the patients, if you don't experience any side effects in regards to your mood, irritability, or depression, have a consultation with a counselor, because it takes time to adjust to the diagnosis. It takes time to adjust to the side effects of the androgen deprivation therapy as well, and counseling can help patients during the hard period of adjustment. Will be sounding like a broken record, but exercise does improve mood and reduces the risk of patients developing depression. Cognitive functions. Patients do experience some changes primarily in a spatial memory. And this is referred to, for example, you start to forget where you parked your car, where you left your key. Patients do report feeling is not as mentally acute as they've been previously, so they can't solve the same puzzle, but it takes them longer to solve the same puzzle as previously. So the recommendation is, well, exercise, stimulating blood flow to the brain, maintains brain health. There are a variety of computerized cognitive training programs that can help patients to stimulate their brain. Also, the recommendation is to reduce clutter in the living space, get more organized, and reduce alcohol and cigarette smoking. Fatigue is another common side effect patients do experience. Unfortunately, again, there is no magic pill to help patients with fatigue, but this is where exercise is the most important. And it's sometimes when I tell patients you need to exercise, they look at me and they tell me, I'm already fatigued. How come you're advocating for exercise? But in fact, it's been shown time and time again through the research that the patients who exercise tend to live longer and have improved outcome, both in their quality of life and longevity. And whenever I talk about exercise, patients tell me, I exercise. I work with my wife for about 1 hour almost every day. So I ask my patients, can you talk to your wife while you're walking? They said, yes. So you're not exercising to the level that you need to exercise. Generally, we recommend for patients to exercise from to moderate to vigorous intensity for about 150 minutes per week of aerobic activity and 2 to 3 resistant training exercise sessions. And the simple way to test it is that walk with your wife. If you try singing, you're not able to sing, and find that you try to catch your breath, that means that this is the level exercise you should be exercising at. And this slide just shows you the example of many benefits of the physical exercise. It shows that physical exercise can improve the effectiveness of the treatment the patients are on, improve brain activity, improve cardiovascular health, improve mental health as well. Take-home message is that there are multiple domains to well-being and for the patients who are on androgen deprivation therapy, and they are all linked. So that's why we recommend for our patients not to focus just on some specific aspect of their health, but maintain rather overall health. And the most common example that I hear from patients is in relations to their sexual function or erectile function, is that we need to get through the initial treatment, we need to get through the initial consultations with with the urologist, medical oncologist, and then later on I will address my sexual function. But generally, the early men start to address all aspects of their health, the better the outcomes. Another take-home message is that there are side effects to the androgen deprivation therapy, but lucky 20% of men won't experience any significant side effects from the androgen deprivation therapy. Dealing with the side effects proactively is the best way to avoid, prevent, or mitigate the side effects. Exercise, again, and healthy lifestyle are the two main things that you can do to prevent side effects from androgen deprivation therapy, and we are here to help you on your journey with prostate cancer.
Okay.